Hi, everybody. This is Susan Clinton, one of your hosts for our podcast, Tough to Treat. I welcome you to this podcast this week. We're bringing in a fellow physical therapist who is going to be presenting a client that is a pretty complex situation. Erica and I spend a lot of time problem solving with her on this particular podcast and connecting some, I think, really important dots. We would love to hear your feedback. And if you are ever ready to bring your own complex client to Tough to Treat, we would welcome you to our podcast. Thank you very much, and we'll see you on the podcast. Hi, everybody. This is Susan Clinton, one of your hosts from Tough to Treat. I'm here with my brilliant partner, Erica. How are you?
I am fine, Susan. How are you?
I'm doing well. Fall color leaves are still happening up here in northern Michigan, so we've had an extended leaf viewing season. It's been beautiful.
And we haven't even started here in New York City, so it's,
you guys are gonna have to get ready. I think you're gonna have a lot of snow. So today, today we're welcoming Darcie Pervier to the podcast. Darcie is an integrative physical therapist in the Boston area, Newport area. You want to tell? I'll let Darcie come on and introduce yourself and tell us who you are and where you're working.
Yeah, so my name is Darcie, and I am from the northern Massachusetts on the coastline, Newburyport area. I treat the seacoast of New Hampshire, Massachusetts residents in a physical therapy practice.
Awesome. And I've known Darcie for a long time. Our paths have intersected and intertwined in different things. And we invited her on because she has a great client she wants to talk about. And we're going to see if the three of us can problem solve some solutions for her.
Oh, awesome. I said one question. Darcie, are you mostly orthopedics, or do you do pelvic health, or do you have a specialty?
Primarily women's health, but really I see people who are just, have failed in therapy elsewhere, and they end up with me in the area.
Perfect. Okay.
And she has a wonderful integrative approach that she uses with people. So hopefully she'll tell us a little bit about that as we move along here.
Awesome.
All right. So Darcie, take it away.
Okay. So I had a patient who is 54-year-old female. And she came in with a primary complaint of low back pain that went into the right leg as her primary problem. But she also had kind of like a burning on the bottom of her feet that happened particularly when she was laying in bed to read at night, but also other times during the day. Her back pain was worse in sitting. And she has a history of thoracic outlet that has been on and off problematic over the last 10 years. She also has dyspareunia, but she wasn't too concerned about that as a primary complaint. Her past medical history is pretty intense. She had several pregnancies, like in the vicinity of like 9, with 6 D&Cs, 3 births. She had an appendectomy with an infection that landed her in the hospital for a few days. Hip reconstruction on the right. And then about 5 years ago, developed breast cancer, underwent chemo and radiation and reconstructive surgery in 2019. And then a couple years later, she fell and shattered her sacrum, which went undiagnosed for about a month. They just kept telling her she just kind of had to wait and the pain would get better. And finally, they did an X-ray and told her it was shattered. And she has a history of chronic constipation for about 10 years. She's been taking Miralax.
Okay. Holy moly.
Right?
Okay.
And her job is sitting, but she does have a standing desk. I should say that.
Okay.
Since sitting. Cool.
I have a couple questions.
Does she use the standing desk?
Yep.
Okay. So before we go forward with questions, just tell us again her chief complaint for coming in to see you. There was a lot of things. Did she want to talk about all of them, or was there like one thing that like, I'm here because of this?
The back pain is the worst.
Okay.
And it's right-sided?
It's kind of central, but it goes into the right leg a little bit more.
Okay. And it's worse with sitting?
And it's really like tailbone. It's like, she says it's low back, but it really sinks down into the sacrum and towards the coccyx.
Okay.
So.
And did the tailbone or back pain come on after this sacral fracture?
Fracture. Mm-hmm.
Okay. So since the sacral fracture, she has had sacral comminuted fracture, it sounds like. She's had back pain ever since?
Exactly. Yeah.
Okay.
And she does say she feels like she's never been the same since cancer, obviously.
Yeah.
But that kind of started this cascade of events.
Okay.
Question: when she's lying on her back and she puts the sacrum like on a hard floor or on like a table, does that bother her, or is it mostly sitting?
She can lay on a plinth, but she can't do, like, she's working with a trainer for a while in the spring, and she couldn't do like sit-ups, anything that rolls over it. And if she's on a hard surface, it doesn't feel great now.
Okay. When was her thoracic? Oh, sorry, Susan. When was her thoracic outlet? How long ago?
That's been ongoing for 10 years. So predates the cancer and reconstruction, but definitely still continues to be bothersome.
Okay.
Okay. So let's sort a few things out here. The burning feet. She's had that before cancer treatment or since? Did you get a sense that was like chemo related?
Right.
Yeah, that's what I thought at first, but she said she was cleared of that. And then we went over it in subsequent visits because I wanted to be certain. And she says that that really didn't start until she started doing her workouts in the spring.
Okay. And where on her feet is she burning?
But the whole foot. She says it can really vary. Sometimes it's just the toes, sometimes it's the heel, sometimes it's, the ball of the foot, sometimes it's all of it.
Okay. Okay. And
question. Oh,
go ahead, Erica.
No. How did she fall in 2021?
Missed a box jump.
So how did she land? She missed a box jump and she landed right
down flat on her. She came down right back onto the sacrum. So flat.
Oh, so she fell backwards.
Mm-hmm.
Okay. Got it. Okay. Go ahead, Susan. That was a big question for me.
And I just want to be sure the sacral fracture was post-cancer?
Mm-hmm.
Yeah.
Okay, so it was, when was it?
Like
2021.
2 years ago. 2 years ago.
2 years ago. Got it. But the burning in the feet and the stuff came on after she returned to exercise from her cancer treatments.
That started this spring. So spring of 2023.
Okay. So it's secondary. It's come on now after we've been dealing with back pain for a while.
Mm-hmm.
Okay.
But were all her births vaginal or were they
vaginal?
Okay.
Yep.
Okay. I think I've got the history here. Tell us kind of where you are with her, what you've been doing, what you found.
Yeah, so I'll go through. I have my list of her objective things to help paint the picture. She has, if we go top down, she has about 150 degrees of shoulder flexion, but only 110 of abduction. She gets really tight through the thorax with squats and overhead attempts for reaching. There's a little bit of a decline in left rib expansion. And a little bit decrease of loading when she does single leg balance through the left thorax. So she has something happening up there. She we did an internal exam. There's about a grade 2 uterine prolapse and a little bit of rectocele symptoms noted, and pretty tight through the obturator internus. On her eval, we found that closed chain internal rotation of the right leg was the closest I could get to provoking her pain.
Okay.
You mean in standing?
Yeah.
Yeah. Okay.
Mm-hmm. Mm-hmm.
Okay. In the internal exams, when you were able to manually palpate the OI, did that reproduce her symptoms?
It was, again, pretty close. So
Pretty close. Okay.
Yep. Mm-hmm.
And then
and bilaterally, I think the right was a little more than the left.
Okay. And you said that some of the pain tends to be a little stronger on the right side than the left side. The mostly central. All right. So that makes a lot of sense, standing and closed chain internal rotation. You said above, when you looked at single leg loading, what did you see her twist with her single leg loading, or was she able to stay pretty straight and just pick the other foot up?
She's able to stay straight, but it was interesting because I'd have her single leg balance and then try to breathe. And with a breath, the left side, the left rib cage had to stay pretty fixed to keep her balanced. On the right side, on right leg balance, she could actually hold herself and take a breath and have some expansion through the thorax.
So she braced her thorax when she was in left one-legged standing. Got it. Okay. Go on.
And that's pretty much all. A little, I'd say she was missing a little bit of internal rotation bilaterally. Man, you couldn't get in externally for OI, like just kind of shuts you out for any of that, even the visceral work. And definitely some fascial restrictions through the lower abdomen from uterus to bladder and all of that.
Mm-hmm. And she had a full, with her cancer treatment, she went ahead and did a full bilateral mastectomy. Is that right? And then a reconstruction.
Yes. And the other thing that's really important is her sternum has no give. It is like a brick wall.
Okay. And just out of curiosity, did they do a DEXA scan on her?
Not that she mentioned as of recently, and we talked about it in the past, but yeah.
Here's the reason I'm drawing that dot together is she's fallen and had a pretty bad sacral fracture. She's had chemo, she's had radiation, and if her sternum is stiff, it sounds like it could be stiff because they tighten that up so much when they do that reconstruction. But the other piece of it that is kind of hitting me a little bit is in the manual therapy world, one of our testing that we do to see if we really need to be doing any kind of heavy manual therapy in the thoracic spine is the sternal test. And you expect the sternum to give when you press on it. And if it's very, very, very stiff, that could be a sign of the hardening cortical bone, which could be a sign of osteopenia or maybe even osteoporosis. So I would think, first off, at this point too, getting a DEXA scan would be important for her.
Yeah, because the chemo is not, that will really reduce bone, right?
Bone leaching. So you're right on track with that by asking that question and going there.
Yeah.
I just wanted for everybody listening out there to I wanted to draw that conclusion. Is why is Susan asking that all of a sudden now? But that would be a cue to me, like, And there's other reasons it could be stiff, but tissue stiffness is different from bone stiffness.
Yeah.
It really depends. Yeah.
Yeah. Darcie, did you check any neural tension testing on her at all?
Yeah. So we did some lower extremity stuff. I actually started her with some just basic nerve glides, like pudendal nerve, obturator nerve, just to try and get something happening there. It didn't change a thing in the beginning. I tried more like standing kind of like a dynamic kind of neural flow with her, and that didn't change anything.
Like a forward bend.
They were provocative. Yeah,
they were provocative.
She's been there. Well, she feels good when she does cat cows. Like if you're just like talking basics, but if I took like the lower extremity through a range to kind of engage from the lower quadrant up, it was a little bit provocative. I can't remember where we got to on that, but so I gave that to her as an exercise for a while, but nothing seemed to change nor improve the symptoms.
Got it. Because the reason I was asking is because with the sacrum and that she when you're falling, you're in that sort of slumped flexion, right? And it could be, and I'm just throwing this out there, it could be I would just put that up on your magnet board. Like there could be a dural neural restriction somewhere in there. Where the restriction is yet to be determined, but that's definitely I would put up on the differential because of the weight, because she fell, and that's why I was like, how did she fall? And also because of her thoracic outlet, and the burning symptoms. I would, and generally dural symptoms, at least in my practice, are latent. They're not going to really feel, they may feel good when you're doing like the whatever, the flossing or the neural. I treat dura a bit differently. I go in through the cranium, but they're going to feel good. But then 3 hours later, they could feel lousy. And so that's very important. If you do any of that with her, ask her to not how you feel 24 hours later, but how do you feel 3 to 12 hours later? Because I've learned over with experience, if that is the driver, we don't know if it is, but they will definitely feel it latent.
So I'll tell you, we have done some. So from like a visceral standpoint, we've done some dural and some inhibition. I've gotten called up into L5 region and to kind of the thoracolumbar junction. And I did do a little bit of cervical cranial work on her, starting farther away. Like I said, okay, you're so irritable. Let's start as far away as we can and see if we can go in there. And again, nothing. I will tell you, it's really the hardest thing for her is nervous system regulation, which I have tried to impress upon her the importance of that and that stuckness and pain. And, we talked about it the last time I saw her, even about, it's okay to recognize your pain, but let's recognize that you're also safe right now. You're okay, but she spirals and so I've done, as much nervous system work before I can get to those things, and I'm still batting zero.
So quick question. Hold on. Did you do like a local listening or a general listening as per like overall? Where were you drawn to? You said like L5?
So at times, I've done it several times. Most recently, taken down to the lower abdomen, left central. So like left of the pubic bone, left side of the area, the lower quadrant, and deep. So we've done, and then her squish test, her compression test, prone, was no mobility on the right. Nothing happens on the right from there.
Got it. Okay.
So it's both general and local listening. Sometimes I think there's a time I've gotten some rectal, like sigmoid colon, some rectum, like some of that happening for sure.
Yeah, I know Susan's going to have a ton to say about the GI stuff. So I can see her chopping at the bit. So go ahead, Susan. I think, that's, I do think that's probably very relevant here.
There's a lot to unpack here. I definitely agree with the work that you've been doing. I would probably be looking a little bit more at the CT junction, just because you've got the upper part with the lower part. And if you can really look at a thoracic slump test versus a lumbar slump. So you keep the lumbar spine straight and you bring up both legs. First, see what happens there. And if she can do that okay, then you just slump the thorax. And you can, if there's going to be a dural piece in there, you can find that sometimes right through there.
We did that last session.
Good.
And like lower. Yep. Sorry, I'm showing you like anyone can see.
We do it all the
time. Lower thoracic, like mid to lower thoracic restriction there, right where she's really stiff.
How's her thoracic rotation?
It's limited. It's probably 50% limited bilaterally. Left is a little better than right.
Have you treated the thorax? Because I don't know your manual background. Have you treated the thorax, not with like joint mobility or anything like that, but have you treated like with breathing, with training and what's the word? Releasing with movement, things like that. I mean, I'm just trying to throw things out. I don't want to confuse people. So has that helped, or have you tried anything like that?
So I started with breath work actually, and getting a little bit of arm movement in to try and kind of bring the rib cage along. We have done a little bit of rotation with some breath work and some manual release, definitely not joint mobilization. But she feels better when she leaves. Like I can get her to feel better when she leaves, but I can't get her to stay better.
She's not carrying it over. So what is she doing at home? Like what exercise is she doing at home?
I have her doing a lot of very gentle kind of total body top to bottom mobility and bottom up mobility. And she can do exercises, but anything that involves slowing down and being in her body and breathing is like terrible for her. She just, that's the first thing to go. She has a really hard time kind of getting in and slowing down enough to do those things. Or she'll do them and be like, I don't know what you're looking for, So I just did it.
So it's not mindful at all. She's not good with imagery or any of that. Okay.
Right. And I think part of it is a defense mechanism that, there's a lot of betrayal happening in that body, in her perspective, that
yes,
it's hard. It's a hard body for her to be in right now.
Yeah.
Yes.
And there's a whole survival mode thing, from the cancer and the need to have everything kind of like, when they go through reconstruction, to kind of like make sure that, that I'm back to where I was before, versus being able to deal with the fact that this was serious. And, so a lot of this is coming, and I agree with you about her nervous system regulation being one of the key things. The last time we talked about her too, we talked a little bit more about her pelvic health and her prolapse. At that point, you thought that maybe the prolapse was secondary to the sacral fractures. Are you still kind of feeling that?
I just feel like her, and she's been in this breath hold position, like there's no mobility in that pelvic floor right now. The operator, like deep hip external rotator, all the deep hip rotators are working on overdrive.
Right.
And so and who knows what's happening for scar tissue. And then she had all those DNCs and all that. And then the appendectomy, there's like a lot of precipitating events for different scar tissue pulls. So I'm not positive. She's a lot to think about.
Yeah, I think there's so much going on. But I think, and also I think the last time we talked to you, talked that she's starting to have longer periods, and things are kind of being wonky around her menstrual cycle as well.
No, she actually, I don't think I said that. Maybe I did. And if I did, I was wrong. I'm so sorry.
No.
Because it was
standing for longer periods. I got it now.
I was like, the chemo ixnayed the menstrual cycle.
Yeah, exactly.
Right.
Exactly. Yeah. Sorry, everybody. We can that little piece there. But I think one of the things to kind of consider here, first of all, obviously, and Darcie, you're familiar with this too, is that it's really hard to have a bowel movement when you have a pelvic floor that's got this going on, plus the rectocele and the prolapse, and some of the things that I think that could help here. I don't know that her tissue would handle a pessary. You'd have to tell me what her tissue kind of looks like. The most interesting thing here is that she probably needs some sort of vaginal estrogen. However, that's a conversation for her to have with her oncologist, even though all of the studies that we have really good studies that show there's just not a big systemic uptake when you use vaginal estrogen, but she still needs to have a conversation with her oncologist. I'm not going to tell somebody to not do that, to have a conversation with them. But there's other that, so DHEA could be something that could be helpful versus estrogen for her, or even if she wanted to do something like Replens. Do just to help the tissue, give the tissue a boost or something that can really help. And at that point, she might be able to tolerate a pessary for this like intense working out thing that she likes to do, or this exercise stuff. But also, while you're working to decrease all the breath holding and the stiffening up of the thorax and everything, because it sounds like everything's just being pushed down and out, which is why the external rotators are working so hard, to hold everything in. What is the strength of her lateral hips? Like glute med, you said she's able to stand on one leg, but she can't let her breath go on the left side when she stands on that leg. So she's using her diaphragm as a postural control muscle for sure. Does she need any capacity building for her, lateral hip muscles and glute muscles to support that area a little bit better so that she doesn't have to work so hard with the hip external rotators? I don't know what you found there.
Yeah, so she definitely is a little weaker in hip abduction. I think that was about a 4- out of 5, if I'm remembering correctly from her eval. Glutes, I didn't manually muscle test, but I can say she's fine with doing, like she was doing squats. She can do bridges. She's been doing all of those things all along. She just has that tendency to kick on hip flexor to try and help stabilize with any of the hip abduction kind of testing that we did. So we had to be really careful about isolating that. So a little weak, but I wouldn't say terribly weak in that range.
Have you, oh, sorry. Yes.
I was just going to say, have you done anything like some, not big ones, but little mini monster walks, with a band around her thighs to help her kind of recruit different? Has she responded to that at all, or has that helped her rotators not kick on so much?
I had her do some standing stuff at her desk because she was so busy. She is just now getting out of her busy season. So I had her doing a little bit with bands, but I also said, just stand and just try to do the different directions, like a standing Pilates kind of. And she does that. She does everything that I can ask her to do. I will definitely ask her to do a little bit more and double down on that for a bit.
Yeah. How does she squat? Have you seen her squat? What does she look like?
She's pretty equal bilaterally. So weight bearing, she's pretty equal between right and left. Appropriate foot response, ankle response, and then the thorax. So she brings her hands forward to counterbalance, but because she's missing that length, she can only get her arms up to maybe a little about horizontal at best, and then that thorax just stiffens right up. So then the movement is happening from the lumbar spine kind of sacral region.
So on the days that she feel like you can get her feeling great after, at the end of the session, what has been your main focus in those sessions where she feels good at the end?
The obturator work, we've been doing some sacrotuberous, sacrospinous ligament kind of immobilization, and a little bit of fascial release, like some fascial release through the lumbar and sacral regions helps. And then if I get up at her neck, upper thorax region, thoracic region, that can help kind of open her up a little bit.
Yeah. Do you do both of those in the same session?
Yes, sometimes not. It depends on the day. I was saying to Susan, the hardest thing for her is I can get derailed from a plan of action. And so then we can end up ping-ponging based on the symptoms. And then I feel like we're not making the progress that we need to in one direction.
Yeah, we've all been there. 100%. No matter how many years of experience you have, I still get derailed. So the reason I was asking is because, there is some connection between the thorax and the pelvis, obviously, right? And whether when you work on the pelvis, it may make something else worse, I don't know, and vice versa. So that's why, and I know it's hard to do, but you almost want to do more of treating both regions of the body, however you treat that, together, and then use some sort of self-check or a thoracic rotation or whatever like do a pre and post and see if like I would treat the pelvis, and then I would just check one-legged standing or thoracic trunk rotation or your Dural test, whatever test you want to use. Then treat her thorax, or vice versa. Treat her thorax after and then recheck, and then the next session just treat thorax first, and then recheck, and then treat them together, because there's some long vector, muscle, fascia, nerve, GI, something visceral, I believe, that's connecting those two, that one gets made worse while the other was treated. Like there's no carryover. I don't know if you think what do you think, Susan? But that's what I'm thinking.
Yeah, sometimes it's just too much input to the system as well. But yes, I definitely agree with the long structure kind of piece that goes from, the head all the way to the pelvis. I have two thoughts. Number one, the sacrotuberous ligament work that you're doing, be sure that you include the hamstring on that one, rather than the spine. Like go hamstring instead, because there's probably a really strong connection there. Where that attachment and stuff happens, and some deep fascial things that'll go into the hip rotators there. That could be helpful for her, and something that she can probably do. The other thing that is coming to mind about the GI system, and I know she's using Miralax, and that's helping, and she probably has a bit of dyssynergia in her pelvic floor. She's got a rectocele, so there's definitely pressures from the GI system. But the thing that just struck me here, listening to this and kind of having a chance to sit back and listen to you and Erica talk for a few minutes, is about tying the with the thorax, like the arm abduction that's so limited, and it makes me think about the flexures in the GI system, the hepatic and the splenic flexures. Something is happening there. And I don't know if the GI system is a problem or if it is a driver, or if it's just two things at one time. But I would think, I'm thinking really being able to get into the ribs on the side from the outside, to get those ribs moving better there. But if you can get into the system, maybe not even the pericardium, but just the deep fascial system in there, to see if you can get that GI system to come down a little bit. It sounds like to me it's being drug up, which makes a lot of sense, because her diaphragm is up and lifted, which means the ventral part of the diaphragm is pulled up towards the back. And, so that's going to pull the peritoneum up with it. And when it does, the descending and ascending are retroperitoneal, but they're being pulled up into that. And that could be a huge issue there, of a tension pattern that is unrelenting. And the only symptom she's getting is constipation, but there can be some viscerosomatic crosstalk in there that you might be able to explore.
And in supine, the diaphragm gets shoved up if they have any sort of GI dysfunction, and that's, from a positional standpoint, that would make sense, right?
But she's had, had a tummy tuck, and she's had, she's had the breast reconstruction, and so everything is tight in there, and so her intra-abdominal pressure is probably very high, higher than it needs to be. And then, of course, when we have, the presence of stool hanging in there all the time too, that doesn't help. But some of that, might be why she feels good when it happens, but it just kind of goes right back up, because that pattern is so strong. And I'm just wondering if you could get, you're doing the external stuff and the other pieces, which are really good, but I'm just wondering, getting in and using the ribs as handles, but also from underneath in the diaphragm, and getting that to start to change some could be very helpful there. Probably why she likes cat-cow.
Yeah.
They're in a position to where her ribs can come down
and
hang. So everything isn't being pulled up and pulled back. So that might be something, if you think. So I'm kind of connecting the dots here, like to what she does all day long. You said she sits, busy season, different things. If she's got a standing desk, it might be cool for her to do things kind of like mobilizing from the inside out, but she doesn't have to. You can tell her it's a mobilization, but it could be something to help with the breathing that she won't do. She doesn't like to do the stuff, but she can have her stand and put her hands on her desk walk her feet backwards so she's getting a little range stretching, and just tell her to breathe, like take deep breaths so we can visualize lungs.
Exactly.
Yeah, things like that, like a hand on the wall, and then using breath along with it. And maybe she could even, you could teach her how to put her hand on her, like on right over her ascending colon, across body while she has so I've got my left hand on the ascending colon, I've got my right arm and 100 degrees of abduction, and she can either take breaths and pull down, or she can, lean up and, kind of like stretch up and pull down. So you can kind of try to get those deeper fascial connections going. But she might buy into this, and it'll give you a chance to kind of introduce breath work to her without her doing, I don't want to
sneak it in. Right. Sneak it in. And
love it.
And no, I was just so fascinated. So I brought these things out, but for the listeners, hold on. So while Susan was describing this abduction and breath work, I would, in a way, she's almost like decompressing her thorax. I would start exploring the abdominal cavity. Is anything being made worse when she actually tries to give herself length in her thorax? Is something turning on? Is something turning on that it shouldn't be? You can even have her do neural glides in that position. I wouldn't go there right yet, but I'm just throwing you these Franklin method balls. For the listeners, they're orange Franklin balls. And so this is what I start patients with. Sometimes if they have a problem sitting and they have a driver in their thorax, I'll have them put them underneath their armpits, like I don't want them squeezing, but they're sitting, they're like this, and they're just relaxing, and that sort of gives them a sense of center. She could do washcloths, but I would try that with her since she has a problem sitting, and that it may make the pelvis worse. I don't know, but I don't know. Okay. So, but I would try that. But the reason why I brought them out is because if she's lying in a position on the table where she can tolerate supine, or, because you need another set of hands, and we all don't have that luxury in the clinic, I don't think we ever have, right? You can be, you want to decompress her thorax, but you need to use another hand to find things that are turning on and feel what her abdominal cavity is doing, like Susan mentioned. Go in and feel her obturator internus. Is it turning on more? Is it not? And you can't do that when you have one set of hands. So sometimes I give them imagery, like, imagine you've got balloons in the armpits. I have them put the balls under their arms sometimes to see if that decompresses. It frees my hands up. It's almost like putting a pelvic belt on somebody to free your hands up, and then go start searching and see if there's anything that was made worse or better with that. And those would be the relevant sort of vectors or muscles to, release. If she's got the balls in her armpits, or if she's getting herself stacked, think of like a kneeling wall squat or a child's pose, and there are muscles that are, or visceral vectors that are not turning on, then you're not interested, right? You want the ones that are really turning on. You can even have her do, as I said, like a neural glide in that position, because you need a set of free hands. And with her history, I think we would all agree she's got more than one driver. I would be 100% convinced.
Yeah, and yes, of course, because she's had the fracture too, so we've got a bunch of things going on here. Also, I think the balls under the arms, and just have her stand on one leg and the other leg and see what gets better.
Yep.
So that way it may be like, if she falls apart, like why? Because you said on the right she can do it, the left she can't. I can't remember which one it was.
Yes, left she couldn't.
So see what happens when you put them in there, and see if you can get that move, after you do some work and she does that, just have her stand up and see, does it clean up? Does it get worse? What happens? And that can also help you and help her kind of see the direction. Like, our goal is for this not to fall apart when we put these in here. So this is why this is an important thing for you to do, or this is an important thing for you to do. This is why we want to add the breath in, to mobilize that, so that it maybe, if she has more of a physical specific goal, she's more willing to do, like I said, hidden breath work and hidden nervous system regulation. Because, it's threatening to her. Obviously right now she doesn't want to sit quiet and go deep. At some point, hopefully she'll feel safer to do that. But right now, just, she's not. So that could be a way to kind of like skirt her towards that a little bit more.
Awesome. Great ideas.
Yeah, and I know Susan, we've talked about this a lot on the podcast before, is changing the environment, right? Like changing the environment, or you talk a lot, Susan, about listening to music and, or just change something. And, even just doing like a kneeling wall squat, just because, and it'll lengthen her thorax. She's got her hands on the wall. I'd be really interested to see, this is just in her one-legged standing, if she is better with imagery or with the balls, but also
and even in, after you do that work, see what her squat looks like. Does she able to lengthen her thorax, for the squat? Or because people with stiff thoraxes can't squat well.
No. But also going on the wall, Darcie, this is what I would do, is just, have her go on the wall just as a quick test. It'll take you 1 minute. Have her go on the wall with a normal base of support arms, just normal, and then very narrow, and then very wide. And you could have a one-legged squat will probably be, one-legged standing will probably be easy because she's holding on, but have her do like a regular squat, or and just see what, or another movement power, split squat or whatever, but see if she's different. Like we talk about in the podcast, standing normal, narrow, wide. See if she is better or worse with a normal, narrow, or if she's different. Forget the better or worse. Just see if she's different, and just throw it up there and just add that to your little diagnostic, because that'll be very telling. She may not be different, and then if she isn't, then just move on. But I think she will be different. I think she'll be worse with the narrow.
I think so too. Yeah. Yeah. Definitely. I'm on board.
Yeah.
No, I think it will be great. I can't wait to hear kind of how things move along. But the other thing is that, does she use her standing desk? Does she notice if she feels different when she's standing versus sitting for her back pain?
It's better. Definitely better with the back pain. She just generally gets pretty miserable by the end of most days because she works really long days, and I'm not going to shift that.
No, you can't. They could only help her control the controllables, whatever she wants to do. Does she do better with things that are guided versus free-for-all kinds of stuff?
I send her videos, and then I think the one she feels comfortable with, and she'll try to do anything. She'll then just does it during the day when she has a break between clients. So she'll take what that instruction was and go for it.
Okay. I'm just wondering if if she had a guided breathing versus a quiet breath work on her own, if she would, because it would tell her what to do, if she would get into that or not, like for 2 minutes.
I could try it with her. Generally, when we've talked about it, she makes a little face.
Yeah. 2 minutes. Like if you give her how about a 1 minute break? Just do this, 4 seconds in, 6 seconds out. I don't know what app she has on her phone. There's so many of them. But you can, she can even just use her phone timer to do that. Just something that's guided that tells her when to breathe in and when to breathe out, so she doesn't have to feel like she's sitting in a corner with her fingertips together doing the meditation pose. It's not going to work for somebody like her, but perhaps if she's standing, she can turn away from her screen and do that for a minute and then turn back. So you can sneak it in and talk to her about the reason we want to do, and you can also give her a reason that doesn't sound like we want to regulate your nervous system, because she doesn't want to get into that, but it could be, this is going to keep your ribs moving. And when your ribs move, see how much better you're doing. So perhaps as a motivator.
And you can integrate that with, that's a great idea, Susan. Have her do like a moot trunk rotation or one-legged standing, like in the morning, and then she can do the breathing, and then she could just check her trunk rotation. Just have her check it and see if, like, at one point during the day, does an actual objective movement get better or worse? Love it. Yeah. And people tend to buy into that. You want to, because you're having them do something, like an intervention, and they do something, and whether it makes them worse or better, there's no judgment. It just adds to the whole picture. Generally,
yeah, it sounds like she's a pretty much kind of outcome driven, and so just continuing to, for the listeners out there more, just continuing to remember that the more relevant the stuff is to her situation, the better. Because she's going to be more motivated to do things that are relevant to her situation. Than just because, well, they just said I need strong hips. For her, that's like, who cares? I'll do it a little bit, but what I really need is something to get this back pain better. And so you've done a great job of really driving everything towards what she wants. It's a matter of kind of just connecting a few more dots, I think.
Right.
She's a very complex person,
yeah,
with a lot of different things going on. Do you have any questions or other comments you want to add, Darcie?
No, I mean, I'm just so grateful. It's just talking it through helps so much to kind of see the dots.
Exactly.
You've got them, you've got all the balls in the air, but now it like pauses it for a second to be like, okay. I can see all of these pieces and how they're intertwined in a way that's just that much more clear than doing it on your own. So I'm super appreciative.
Well, we're glad you're here.
Yeah.
It's the reason that Eric and I started this podcast in the first place. Before we had the podcast, we got on the phone to talk our way through things. Then it was suggested to us to do the podcast, and we've been talking our way through things ever since. But we love having people on like you to come in and bring us cases so we can hear what other people are working with and have the ability for three of us to talk things through. Really helps everybody out there listening, because they have similar people and similar things, and it helps kind of like, oh, maybe I could look at some of these things with my client and see how that would work for them as well.
Yeah.
All right.
Yeah, it's amazing. And we all have tough patients, and I get mentored still, and it's you can't do it alone. I mean, it's very, especially if you've been treating them a while, and you just need another set of eyes or ears, and everything that you've done is like, oh, of course, you actually connect the dots. So I'm so interested to see how this patient fares. Please keep us posted. Fascinating.
Well, thank you so much.
Thank you, Darcie, for your time and coming on. We really appreciate it. And for everybody else out there, thank you so much for taking the time to listen. We look forward to your comments. Drop us an email at toughtotreatpt.com. Gmail.com. I get it wrong every time. toughtotreatpt@gmail.com. Yes.
It's okay, people. toughtotreatpt@gmail.com.
There we go. And follow us on our website and jump on social media and chat with us. Let us know what you're thinking and what's going on. If you want to come on the podcast, let us know.
Yeah.
All right. Thank you, everybody.